We have a wonderful program for you this morning and this afternoon. Our first session is a presentation from a working group that the Center for Theology and Ethics has put together, the working group on AI and Catholic healthcare. The working group is currently writing a white paper. We've got 15,000 words. We could, does anyone want to read a 20,000 word white paper? I see one hand. It's Tom Bushlack. Thanks, Tom. We're about 2/3 of the way through the writing. We're gonna have that long white paper. We'll distill it down in a variety of forms, and you'll all run it through ChatGPT anyways. We know that, so you'll get your own 7,700 word summary. But we found we're about 2/3 of the way through, and we're really beginning to think about the normative guidance that we want to provide. And we talked about this in a meeting we had a couple days ago here at BC. And we want to bring some of that to you. We want to introduce you to what we're doing. And then we want to get your feedback. We've got an incredible group here. We want you to help us to shape the paper that we think will be hopefully a landmark paper in the field. And so we're going to ask you to help us to do that this morning. There are 6 members of the committee. I'm the chair, Kathy Curran, who's the Senior Director of Public Policy at the Catholic Health Association of the United States, is on the committee. Anita Ho serves the Common Spirit Health Ministry as the California Region Vice President of Ethics. She is also Associate Professor at the UCSF Bioethics Program and Clinical Professor at the Center for Applied Ethics at the University of British Columbia. Anita, you can't find another title. You can't find another job. You've got 3 different. Paul Sherz is the Our Lady of Guadalupe Professor of Theology at the University of Notre Dame and a program chair for the Notre Dame IBM Tech Ethics Lab. And Mark Townsend serves as the Chief Clinical Digital Ventures Officer for Bon Secours Mercy Health. And Byron Yount is the Chief Data and Artificial Intelligence Officer at Mercy. So we've got a great group, a very diverse group of skill sets coming to this paper. So what we'll do now is I'll briefly introduce the purpose of the paper, and then each of us will come up and discuss an aspect of the paper. Then what I'll ask you to do is kind of get with your people around you to talk about what we've presented, reflecting on that in light of what we heard last night. And then we'll come together and you can provide us some feedback. So the purpose of the paper is to provide ethical guidance, as I noted, to Catholic healthcare systems. First, to raise up Catholic values, we want there to be a thick ethical lens that really represents what Catholics believe about how healthcare should be delivered, what the purpose of healthcare is. We want to generate general norms. So to provide guidance, I mean, people are looking for guidance. Systems are looking for guidance. Is there consensus on certain issues? We want to be a member of that dialogue to begin to create and generate consensus. But we also want to respect subsidiarity. We are not going to descend into the details and, having rules on every aspect of AI. That would be a violation of subsidiarity. We would be, it's decontextualized. You don't do ethics in that way. So the guidance is going to be, I think, substantial, but also general. And then the onus is on the systems and the ethics leaders and mission leaders to apply that in their own contexts. The paper is grounded, as you'll see, in use cases and the effects that those use cases either are having or may have on patients, on communities, and on healthcare professionals. And also, we could say, on the patient-professional relationship, very much focused on that. And as we discussed a couple of days ago, we're thinking this is something that will need to be regularly revised. We'll present this. Hopefully, it'll come out sometime in the fall, and we'll send it to all of you, so you'll have it. And then we'll regularly revise it in light of changes in the landscape in healthcare and in AI, because we cannot predict where it's going, but we want to be a part of that ongoing conversation. So that's a little bit on the purpose. I will now invite Mark Townsend up to talk about some of the use cases.
Morning. So as we set out to try to capture some of the use cases that inform the work of the working group, it's interesting in the 9 months that we've been in this space, the use cases have evolved very significantly. And so 2025 is now recognized as the year of agentic AI. And as we began this work, we didn't know that 2025 would be referred to as the year of agentic AI. Agents are out there. Digital agents have been out there for some time, but increasingly they're being personified, and increasingly they are taking on a life of their own, if you will. This slide is essentially a framework of how we're looking at the use of agents in healthcare, and how they inform the work of the ethics working group. So my background is to have had a parallel career in healthcare delivery as a cardiologist, in parallel to an administrative career that consumed my clinical career. But I'll use the framework of a practicing cardiologist, for example, as an example of the use case here of an agentic persona or an agentic AI. So as a practicing cardiologist, I had nurse practitioners and I had PAs working under my license through a collaborative practice agreement. And so they were essentially an extension of my ability to treat more people. So in that framework, that team of individuals working under my license had some autonomy, but quite frankly, if we collectively or collaboratively took a misstep, it was my accountability. It was my license that was on the line. So that's the framework that is being applied to these agents, because from a regulatory perspective, the regulation, and Kathy will talk about this a little bit later today, the regulation, quite frankly, cannot keep up with the pace of the technological advancements. So to now use that term, an extension of my practice, it was a little bit inflammatory to call nurse practitioners PAs physician extenders. They're now called APCs, advanced practice clinicians, or practitioners or providers. But agents don't mind if we call them extenders. So calling agents extenders, digital clinician extenders, is essentially what we're seeing hitting essentially prime time. So since we started this working group, Epic released 3 personas: Art, Emmy, and Penny. They're all digital assistants, and they all work in the space of an extension of the license of the clinician. So for example, Art in the acute care side, on the day of discharge, can help a physician with discharge instructions. Nurses actually document in Epic, for example, or electronic health record, they document the instructions, and then they assume the responsibility under their license for the work of the agent. And the agent, in some cases, starting to do preliminary documentation in Epic. So now, if you take that same digital clinician extender, the next day, for example, there may be a care coordination nurse who calls a patient as the patient has been discharged, is now at home, and that voice agent is asking questions. Do you understand your discharge instructions? Did you get your medications refilled? Do you have a ride to your appointment? Do you have your appointment set up? That all then is written into Epic and documented in Epic, and then a nurse, again, will take responsibility for that, review that documentation, and sign off on it. So it's an extension of that nurse's license on the second day, same agent perhaps. The third day, for example, the patient may have a follow-up in clinic, and you can get a phone call essentially from an agent saying, do you know where the clinic is? Do you know what time your appointment is? Do you have any questions about it? And oh, by the way, what medications are you taking? It can start essentially to generate that documentation before the patient even arrives in the clinic. So all of those are use cases that are out there. We have been in this space at Bon Secours Mercy Health developing a precision digital navigator, and Andy Parham is here, has been on this journey with us. Let's just say this is a complex space to be in, because it pulls in regulation, it pulls in governance, it pulls in ethics. It is just moving so quickly. And by the time you think you've figured it out and you've created a policy, quite frankly, the technology has moved and you have to react. So it's like trying to put together a policy that governs the use of the internet. We've all moved past that, but that's what we're grappling with, right? So in a future use case construct, this is not that far away. And Monsignor referenced this yesterday. So humanoids are out there, and this one may be branded Tesla, but Xpeng's Iron as a humanoid is another version of these. And these humanoids, for example, we hear will be in mass production perhaps by the end of this year. Tesla has shut down 2 of their their assembly lines specific to automobile manufacturing so that they can pivot to create what Mr. Musk calls an army of humanoids. So Optimus as a humanoid, is there going to be a place in healthcare for a humanoid? And that poses all sorts of questions that we've been grappling with together. So Anita will, I believe, take us into a little bit more of that framework.
Thank you so much, Mark. I'm not going to talk about humanoids though at this point, in part because maybe I'm fearful of that future in some ways, particularly for Catholic healthcare, in relation to what does it mean to still center the humans, center the common good and the accompaniment in relation to thinking about AI ethics. So as Dan mentioned, that we have got this 15,000 word essay paper currently. But what we're really thinking about is how we actually are still centering everything that we are doing in Catholic healthcare in relation to thinking about the common good, in relation to thinking about the human dignity. So what we see is that there are really intersecting layers that when we're thinking about how we actually serve every person who comes through our ministry, the patients that we have, the healthcare providers, the clinicians that we work with, other workers who are also actually contributing to the care of every person that we are serving. And then also thinking about the healthcare organizations, right? The ministries that we are serving in. How do these needs, the opportunities and challenges also intersect? And recognizing, especially in Catholic healthcare, that our focus is really on those who are poor and vulnerable, especially those who have been socially marginalized. How would we make sure that when we are using AI is really promoting their good and promoting their agency as well? At the same time, recognizing everything that we're doing with AI may also have an environmental cost to it. Writing a 100, so because we write it, so that's okay, I guess. But if we're writing even just 100 words with AI, that's going to cost one bottle of water, the equivalent of one bottle of water, just for 100 words, partly because of the water that it needs to be used for cooling data centers and also powering these data centers as well. And that's also the equivalent of 14 LED light bulbs for 1 hour. So as we use it for different purposes, sometimes the ethical part is not just the ethical dilemmas that we see with the severe kinds of cases, but also it's just the small actions that we are doing may still have an impact in relation to our ministry. So what we have found in our work so far is that there are some themes, again, kind of thinking about the different layers of impact on different people that will be, part of this whole ecosystem. We do see, as Monsignor mentioned yesterday too, it's not just about preventing harm, but there's also opportunity that we have. The more that we can think about how we can care for our patients in reducing the cost, in reducing the burden that they may actually have to encounter when they're receiving care and going through the whole healthcare journey with us, then it's also serving their good. What we're hoping, of course, is that the use of AI can have more precise and accurate diagnoses for all the patients that we're serving so they can have more personalized care. At the same time, we are also seeing that the more information that we get from our patients, especially in contexts that they do not actually have the opportunity to consent to or refuse to consent to each data point, we also have to think about how to protect their privacy, because that's also part of the dignity as well. And as we get more and more information about patients, how do we make sure, especially in Catholic healthcare, that people don't get just datafied, that they become numbers, math, and all just information? People are not data points. There is still, when we think about the image of God that was being discussed yesterday as well, that the more that we are thinking about patients in terms of data, there is also the concern about how that may depersonalize and de-dignify the human being. Of course, our patients are also interacting with our clinicians, with other ancillary caregivers as well, who touch all our patients in different times. So we also have heard lots of information from clinicians saying about how, especially in relation to AI Scribe, that is really promoting their well-being. And I think Professor Yang also mentioned yesterday how then physicians and nurses and so on can actually spend more time with patients rather than looking at computer screens. So in many ways, that can really promote the dignity of work and clinician well-being. And that hopefully that can also allow us to spend more time on the true healing and compassionate accompaniment of those who we are encountering. At the same time, as we roll out more and more of these AI tools, there may also be questions in relation to whether clinicians may feel overwhelmed and whether they actually have agency in determining when or how they would be using these tools that we are implementing in our ministries as well. And how may that provide positive and at the same time also potentially negative patient and clinician relationship as well, especially if patients think that they are actually now spending more time with the digital tools rather than the human clinicians. So that also has an impact in relation to how we are operating our ministries as well. Certainly, we have already heard quite a bit in relation to potential better workflow that our ministries may experience. AI may be able to also help us to reduce redundancy in many of these situations. And if we can do that, we can also steward our resources accordingly to actually better serve our communities. At the same time, Mark and we were talking about change without the management. And so in many ways, we have to also see whether our workforce, our communities are actually ready for some of these tools as well, because there may be tremendous upfront costs for unknown benefits. So how do we make sure that when we are actually thinking through the AI life cycle, that people are actually prepare for that and they don't feel even more overburdened when they're already exhausted in the current healthcare climate? And that also really helps us to think about, again, the communities that we are serving, particularly those who may already be marginalized. We have already heard yesterday, and even when Mark was talking too, about how to think through the impact on those who may not have access to care. In many ways, we may be able to now provide more resources to patients who are in socially marginalized groups. We can use AI, for example, to produce discharge summaries in different languages. So patients and families that are coming from different linguistic backgrounds may be able to have actually more resources to support their care and ongoing care. That may also help to promote health literacy for people who otherwise may not have the information. And that may also allow us to think about how do we actually provide better community benefits, especially if we can be better stewards of resources. At the same time, again, if we have more and more information about the communities that we are serving, there may also be questions about privacy, especially if we are using a lot more data from patients who otherwise may not have access to begin with. So there may be the concern about the distribution of burdens and benefits. We have already heard lots about AI algorithmic bias, and Monsignor mentioned yesterday as well, especially when we are often collecting data from people who are already relatively privileged. They have access to care, they have access to research. And so we have to also be concerned about how some of the algorithms may not actually be accurate for those who are underserved. So in many ways, and they may also be thinking, why should I be actually devoting my data when in the end, some of these tools may actually further stigmatize or disadvantage myself or people like myself. And as we are trying to really roll out various kinds of tools, some of the tools about having people being monitored at home as well may actually only work if we have good digital infrastructure. So in urban areas, for people who can actually afford the data, that's not a problem. But especially in rural areas, when we think this may actually work best, structurally speaking, we still have to ask different kinds of questions in relation to how we can make sure people have the digital infrastructure. So that in many ways, as we are trying to put more care burdens on people themselves, so the responsibilities on people themselves and the families who may be caring for them also, we also have to be very mindful that there may be concerns about the digital divide as we actually put more and more responsibilities on people themselves. And certainly there are also environmental concerns that we have to think about. On the one hand, AI may help us to be actually more efficient with energy use in the ministries, clinics that we are serving. But at the same time, as I briefly mentioned, and I know that there is at least there are a couple sessions today that will talk about environmental impact as well, that may really be the opportunity for us to think about as Catholic healthcare, that as we try to innovate, how do we do it in a responsible way? Because we really want to make sure that the tools that we're using truly have clinical and human values, so that we can actually really serve the common good. Because otherwise, even if we are not talking about tools that are specifically dangerous, the more that we're using AI for things that may be more frivolous and not truly really serving our good, that there may be substantial environmental and social costs for our communities and the future generations to come as well. So then I'm going to turn back to Dan and Paul to talk about other broader questions. Thank you.
Thank you. Thank you, Anita. So I'll talk a little bit about the lens that we're using, the moral lens that we're using to analyze these use cases and themes and topics. You know, this gets, first of all, at what's the mission of Catholic healthcare? It's really to continue the healing ministry of Jesus Christ, as we mentioned last night. And that healing the sick witnesses to the kingdom of God. So as I read in that quote from Luke, you know, the disciples were to enter towns and heal the sick and proclaim the kingdom of God, that the kingdom of God is at hand for you by healing the sick. It's a privileged way of disclosing God. It's a way of God communicating to humanity by healing the sick. And then his followers are invited into that. It doesn't end with Jesus's death. It continues through his healers all the way till today. And it's you know, these massive organizations are still carrying it on. It might be harder to see. You know, it looks a little bit different in the Gospels than it does in these big organizations that we have, but the call is no different. And you know, and it's a ministry. A ministry is a public activity on behalf of the church that's enabled by God's grace. So it's unique in that way. It's a ministry, so it's public for the good of human beings, and it's grace enabled. It's not possible without God's grace operating. And as we know from Gaudium et Spes and just any good theology, God's grace moves through the world, not just through Christians or Catholics or, you know, God's grace can move through any human being and does. A big part of this is healing. What is the healing? What does it mean that it's a healing ministry? Well, healing is restoration to wholeness. It involves the whole person, the physical, the psychological, the social, the spiritual. Healing touches everything. And certainly medicine is primarily aimed at the physical, the physiological, and the psychological, but it has to recognize the social and relational and spiritual aspects of the person. Well, it doesn't directly treat those with medical interventions. It has to respect those and understand that all of that medicine and care that's delivered is for greater goods, right? We don't live for the sake of life. We're not healthy for the sake of being healthy. Life is lived for the sake of greater goods, specifically the love of God and love of neighbor, that we know is the goal of human existence. And healing is relational. It's clear throughout the scriptures. Jesus heals in a very relational way. The disciples healed in a very relational way. The history of Catholic healthcare is very relational, not merely technical, but there's a relationship, the therapeutic relationship between the professional healer and the patient. And it's aimed at ultimately, when we talk about healing, it's aimed at human flourishing. Now, again, a medical intervention doesn't directly cause human flourishing. Human flourishing is an act. It's an activity. It's a way of life. It's something a person does. Again, it's a verb. You think of it as a verb. It's you do your flourishing in that way. Health is a part of human flourishing. We cannot flourish if we lack all health, if we're And there are, we can massage that as well. I mean, there are ways that there's good research that persons with disabilities flourish. It doesn't cut them off from flourishing. But they have a certain level of health. And we know intuitively through our own experiences and the experiences of others, health is core to our human flourishing, as is our friendships, our relationships, our practice of the virtues. We don't flourish if we're vicious. Our flourishing has to do with us doing the good, becoming the good, having meaningful work, enjoying leisure, enjoying the arts, and our relationship with God, spirituality. All of these things are wrapped up in what it means to flourish as a human. So it touches every aspect of the person. It's not just our health. What healthcare can do is it can create possibilities of flourishing for people. And that is the goal, that healing can create possibilities of flourishing. And finally, when we think about the healthcare ministry, right, what it is, there are virtues that are wrapped up in that. There are practices, there are certain traits that we need. In order for us to heal, we need to embody and practice certain traits. And, there are many, and I've just, selected 3 from the paper that we're developing. One is mercy. Mercy is core to, caring for the sick, nursing the sick, visiting the sick is a work of mercy. We find this in Matthew 25. Evidently we'll be judged on a number of different things, and one of them is, did you heal? Did you nurse? Did you visit the sick? St. Augustine in the City of God. I could have quoted Aquinas, but he's passé now that we have Pope Leo. So I'm going to go all the way back. Aquinas actually gets his definition of mercy from Augustine, so I'm going to go back to the source. Mercy is compassion in our hearts, evoked by the misery of another, and compelling us to offer all possible aid. It involves both internal movements and external actions. Mercy is not just something that's done out in the world. It's something that exists within us and then is externalized. So when we think about AI and we think about AI as merciful or empathetic, we have to understand what a virtue is. A virtue has internal realizations and external realizations. It's not just a behavior. It's not just a performance. There's something internal to us that moves us to do that. That's a true virtue. Solidarity, where we have common cause with a group who suffers. So if mercy is directed to individuals who suffer, that person there who's suffering. Solidarity is aimed at a group who suffers, people who have been marginalized, ignored, put to the side in community. That we have common cause with them. We suffer with that group. We don't let them suffer alone. Suffering is inevitable in human existence. What is not inevitable is that human beings suffer alone. The only thing worse than suffering is suffering alone. And the call of Catholic healthcare is that no one suffers alone, no one individual patient, and no one community. We tie ourselves to their suffering. We suffer with them to elevate them to healing, to wholeness, to flourishing. And finally, prudence. We need to discover the right way to do the good. Loving is not enough. Loving people is not enough. We can love wrongly. I've got a 15-year-old son. If I was making his bed every morning, I would be loving him wrongly. He needs to learn how to take care of himself. Even if I did that out of love, it would be the wrong thing to do. Prudence is that virtue that helps us to love rightly, given the circumstances, to find the right way to enact our mercy, our solidarity, our love. And we need that more than ever in a world in AI, with these complex circumstances presenting themselves to us. So now I'll turn it over to Paul Sherz, who is going to bring us through the recommendations that we are beginning to develop.
Great. Yes. And so from that analysis of use cases and different themes, and we have developed a set of norms that can guide how AI can be applied in ways that ensure that it serves the healing ministry of Catholic healthcare. So the first is that it should be aimed at flourishing, right, which is the goal of human life. It shouldn't just be about optimization or efficiency. It should aim to help the flourishing of patients and practitioners in the systems. And people who we should be especially concerned about are the poor and the vulnerable. Preferential option for the poor has to guide AI adoption, which means we should guard against unjust bias, make sure that it doesn't increase health disparities, but instead reduces those health disparities. AI should strengthen the patient-professional relationship rather than weaken it. And Anita was talking about how AI scribes have a tendency to support healthcare workers, but also allow them to interact with the patients more. That's a way AI can strengthen it. But then you could see that you could use AI chatbots to replace clinicians, and that would be a way to undermine that. There should always be a role for ethical responsibility in major decisions around patients, right? There should be always someone accountable for those kinds of judgment that can be traced. AI should also be used to expand access. It has an amazing ability to increase the availability of care and also to reduce the cost of care if we deploy it correctly. We should think about mitigating the environmental impacts of AI. Right? This should be something that should be under consideration with major investments in healthcare tools, or if you're deciding between two, try to determine which one has less impact. We should not anthropomorphize AI. AI tools are not persons, and patients shouldn't be confused by this, especially when you're dealing with patients who could be delirious or could have not much understanding about what these tools are. So, I mean, AI tools should never represent themselves as persons, and they should never ascribe to themselves emotion like empathy and compassion. And we should be very careful about language, what AI tools are ascribing to themselves. And AI tools need to respect the dignity of work. Right? They should be improving the working conditions in Catholic healthcare rather than merely being used to increase tempo of work or the intensification of work. We should also guard against de-skilling, right? Where people just become the hands of the machines rather than being able to use prudential judgment and their own virtues of mercy in the care of the patients. And we should consider job losses due to AI. Can be careful about who is let go, try to maintain work, and also provide reskilling and retraining for those who might be whose jobs might be eliminated by use of AI. So those are the general norms that we've agreed upon so far, but we also had some norms that we had questions and debates about in our committees about how should we think about these issues. The first one involves what should be the norms for data protection, privacy, and commercialization. Right? So a lot of health systems are using their data in many ways in relation to training internal and external AIs. They're using patient data, de-identified data, aggregate data. Each of these things raise really important issues, right? And some of the debates regard, on the one hand, we want to think of healthcare systems as learning organizations in which data becomes very important, but there are times when this can become the exploitation of patients or the commercialization of patient care. Right. And so how to draw those lines is something we'd love to have advice on, or even we've considered this might need to be something that is a separate white paper, how to deal with privacy and data. The second is, what is proper disclosure of AI? Right. So patients should be clear when they're interacting with an AI chatbot, even a major kind of moment of diagnosis driven by AI. You would think that would be part of informed consent. But then, as many people have noted, AI is everywhere in Catholic Catholic healthcare. It runs the elevators in the hospitals, right? So not all of that needs to be disclosed. Billing doesn't need to be disclosed, right, with the use of AI. But where is the proper line of disclosure? Third, what are the moral limits of anthropomorphizing AI? So clearly, the chatbot shouldn't claim to be a person and describe emotions to themselves. But should there be limits on how kind of humanized an avatar should look like? Or what are the conventions around naming and things like that? So those are things that we've debated about. Fourth, one of the areas about AI and access that we're concerned about is many of these tools like mental health care chatbots, like Wobot is the example up there. People have thought about using them. We don't have enough psychologists or trained therapists. So maybe to fill that gap, we can use these AI tools. But on the other hand, we have a real fear of creating two-tiered systems where you have stratified care where the poor get chatbots and the wealthy can access like actual human care. And how do we guard against that is something like this division. And the other way is once you have those tools filling the gap, there's a way in which it could push against the structural pressures to actually increase the number of therapists. And last, we've been debating how do we write this report to make it of ongoing applicability. As Mark said, since the fall, the number of use cases has expanded. Agents went from being something where we were thinking about implementing or initially implementing to something that's actually already there. And so the way we've been doing this is thinking about general norms, using use cases as kind of models of deliberation, rather than kind of very specific rules, but any other ideas you might have for how to make this of ongoing applicability in the future would be very helpful. Yes. So with that, we'd love to hear your thoughts on what we presented here on the norms and all of that, and in relation to what we heard last night. So thank you.
So we have mics passed through the room. So if you have a question, I see Lewis, and I'll.
Lewis Kim. I'm not sure if it's right for the white paper, but when I think about constituencies that you're addressing, patients, clinics, institutions, I'm mindful that when we think about healthcare, we sort of subconsciously think about the current model of institutions, credentialed professionals, et cetera. But we've all experienced that when we have a health crisis, family members get pulled in, caregivers get pulled in. And if AI can expand capabilities, I wonder if there's an opportunity to think about how AI can also enable non-credentialed professionals, family caregivers, and particularly in the area of like spiritual health and spiritual distress, and maybe parishes can get involved. I just wonder if that's a topic for also the white paper.
I'll take that. We haven't included that as part of the white paper. I know that Jill Fisk, who's here from CHA, is thinking about that, the use of AI in spiritual care, pastoral care. So I'd invite you to have a conversation with Jill. But we're trying to keep the scope as narrow as possible, given that the topic is huge, and no one wants to read a 40,000 word white paper, let alone a 20,000 word. So no, but I think you're absolutely right. I mean, there are ways that we can leverage that in that direction. And I think that conversation seems to me to be just beginning. And again, I think Jill could speak to that. I think there's a lot of work that needs to be done in that area. Yeah, but it's a good question. Not something we're going to take up in this paper, though.
Can I take it up? Not in the paper, but I think that's a great question, especially as Catholic healthcare are thinking more about the continuum of care as well, right? So people, especially when we want to discharge patients back home earlier, hopefully with family support, I think it's also really important, not simply to give family members and other informal caregivers the tools, but also recognize that when we do that, we're also putting other kinds of burdens on family members as well. So how do we then have a much more holistic way of also supporting these family members, many of whom are women, many of whom are also in the sandwich kind of generation right now, that they may be caring for children, they may be caring for elderly as well. And so that when we're giving them tools, we're also thinking about how do we support them in a more holistic way, so that the healing is not just for that person, but that for the whole family together.
Thank you. Other questions? I see right in the middle of the side here.
Hi, thank you. My name is Weizhi Cheng. A question I had is whether or not this white paper engages with the concept of conspicuous consumption, because I think the converse of making healthcare more accessible via AI is to make human healthcare, human caregivers more rare, more valuable in some sort of context. And so if under conspicuous consumption, human healthcare is perceived as a luxury good, I wonder if that creates incentives to move more health providers towards the high-end luxury healthcare as opposed to care for the vulnerable. I think with the wellness industry, there's already some trends towards this direction.
Paul, yeah.
Yeah, and I think that's what we were trying to deal with the realm of stratification, right? I think that that is a major concern we have and that we're going to deal with. But on the other hand, I think a lot of the medical care that's going into concierge care, some of it's, or kind of this high quality one. Some of that is about conspicuous consumption, but some of it is about healthcare work, doctors and nurse practitioners who don't want to have the pressure of all the paperwork and the insurance problems that you can get in these large systems. So I think if we can use AI tools in a way to allow for a better physician-patient, practitioner-patient relationship, that might relieve some of those pressures and reduce the amount of paperwork they have to do, things like that.
I see a question right here up front on this side.
I'm talking from the perspective of I have a 31-year-old daughter who just is going through some healthcare things. And what about, I hear you saying physician-patient relationship. How do we find a way to advocate to give greater voice to the patient? Because AI, oftentimes what I watch is it could be more empowering because when a young person is wanting to be healthy and is talking to a practitioner, sometimes we're limited to the practitioner's knowledge, whereas the AI and the intake of the information that that person's trying to say could get clearer into the AI knowledge base, because there are sometimes I just wanted to scream because I'm a CEO in healthcare. I know when it's broken. Yeah. And I know when the person's distracted. There's so much good that it can do, and empowering the patient. It's not about how we should limit it, but how do we find a way to channel it?
Mm-hmm. Mark,
yeah, that's a tremendous use case. And to the extent that the technology can be leveraged to be more comprehensive with intake, to spend more time, not rush essentially the interaction, there's definitely advantages, and that is very well articulated. That's been studied as well, and there are instances where patients will prefer that type of an interaction versus a human interaction, which is by nature perhaps going to be more rushed, less comprehensive. Somewhat akin to, for example, a history and a physical done by a medical student versus a history and a physical done by a mature physician who's busy and constrained by time, right? There's a big difference, particularly in the documentation of all of that as well. And Byron, I think you guys are in the front end of this as well.
Hear me? So I think to a certain degree, there's emergence of AI. It's now patient facing. But what's that? Oh, okay. But some concern, right, in doing that. That's kind of been a little bit of the last frontier for health systems, because it's more out of your governance and your monitoring, as opposed to what you're using internally. If you were to open up Mercy's registry today, you would find 364 AI-enabled products and services in use. Those touch nearly every caregiver that we have within the ministry. That's thousands, and ultimately millions of patients, and then ultimately millions of family members. But this year, just in the seat that I have, I get pitched to all the time. Lots of products, lots of services that are trying to envelop the patient into that care team, that care journey, and the patient's family into that care team and care journey. And in fact, IMI, right, the Epic product, I think, is a patient-facing application that's trying to net together what is happening with the care of the patient into more deeply into the relationship with the care team and the care provider. So hope on the front, it's how it's executed. at the end of the day. I don't know if that's helpful, but what I'm seeing.
I see Constantine and then Peter Cataldo has a question in the back, and then we may be calling it shortly after that. Yeah.
Thank you. Thank you very much. So Konstantin Psimopoulos, I'm a bioethicist with the Human Flourishing Program at Harvard. First of all, I want to applaud you because I saw that you have a lot of emphasis on human flourishing, which is what should be, but I'm biased, of course. But I wanted to ask you, I'm wondering if you wanted to use any kind of metrics for AI in terms of human flourishing. We recently published a couple of papers with my colleagues Tyler Vanderville and Jonathan Tubner. And actually one of them was submitted to a call for the AI plan from the Office on Science Technology Policy at the White House. So I was wondering if you have considered that, and if you haven't, because it just came out, I'm happy to share, but we have specific metrics aligned with our 6 measures for human flourishing. So thank you.
We haven't gone in that direction. I mean, I think, and I really applaud the work of the Human Flourishing Center at Harvard. The work that you and your colleagues do is really incredible and important, and you've certainly elevated the conversation around flourishing in an important way, and so it's been helpful in that way. I mean, I think certainly we can have metrics and measure for these things. I ultimately think human flourishing is a transcendent reality. These certain things can't be. It's emergent. It's personal. It's as the Monsignor said last night, there's a certain mystery to these things. And that doesn't mean you can't try to measure for it or approximate it. I think that's important. We just haven't gone in that direction. I don't see us going in that direction, but I think we can have conversations after the paper and we can talk about ways to collaborate around that. And I would appreciate that. Peter in the back. And then Barrett, we'll have one more in the front. Barrett will have the final question.
Thank you, Dan. Just wondering if you plan either with recommendation number 7 or somewhere in the paper to address the Catholic philosophical and theological tradition regarding the body-soul unity, and also the need to resist the temptation to model human intelligence and human agency after AI.
Yeah. It's a great question, Peter. The paper does have that. I just wanted to present the moral lens, but we've got an anthropological aspect to the paper that precedes that, in fact. As you know, moral theology is downstream from anthropology, theological anthropology. So yeah, we go into depth, we go in depth on the theological anthropology, you know, very much in line with Antiqua et Nova, which, as you know, is more focused on the anthropological aspects of the disanalogy, as they write, between human beings and human intelligence and artificial intelligence. They say the analogy fails, essentially. To call it artificial intelligence is a misnomer. It's augmenting the intelligence that we have. It is not intelligence in and of itself. We use that as an analogy, but again, there are deep limitations to that. We do surface those in the paper, and I appreciate that, and we'll certainly make sure that that's amplified to the point that it comes through very loud and clear in the paper. And we've got a question right up front here, and that'll be the final question, and then we'll move on to our next session.
So I'm thinking a little bit about institutional norms here, because as we saw with software as a service products, the adoption was subsidized by companies, by venture capital. Healthcare systems adopted software and then prices jacked up, and then you had to absorb the cost in other areas in your healthcare system. I'm curious how or in what ways you've thought about down the line, given that you're getting pitched constantly for AI products, what the kind of first adoption push means for these norms when your institution, when Catholic health care is now in an involuntary dependence on these tools and then need to pay for them somehow. So I guess, are there norms you have that you're thinking about for that point?
Mark and Byron, I think you would be.
So we did have our logo up there on behalf of Bon Secours Mercy Health. Crete Health Partners does strategic investing and is a bit of a VC on behalf of the health system. And that's a tough question you're asking because, and I'll just tell you the way that we've addressed it, and then Byron can tell you the way they've addressed it. The way we have looked at the problem statement is to say that our operators, our clinicians, our people doing administrative jobs have specific needs. If they surface those needs, those are the use cases. If there is an existing technology that can meet those needs, that's great, in which case you can just jump on in. But in many cases, we actually find that there's white space and we have to develop or co-develop technology in that space. And it creates a little bit of a paradox because internally, from an operational perspective, that project has to live and die based on its own operational merit. So it actually has to return value, and value is a hard thing to measure. And so we use the surrogate of profitability, and it's a little bit crass. But are you making revenue? Are you adding to the bottom line? And if you're not, then can we really afford the luxury in that space? And then that's one half of the argument. But the other half, which you nicely articulated, is then the venture capital side, which is, but you may be able to create value through investment in that space, right? And is that the right thing to do? And so in each of these conversations, we actually do a discernment process where we partner with our mission team, and Father Joe Cardone and his team will help us discern essentially whether or not it is the right thing to do for us and on behalf of our operators, just because we can create value through generating returns by investing in a technology that is up and coming may not be the right thing to do as well. And so it is a tough space to be in, and there's a lot that is evolving. We haven't really gotten into venture capital's role in this white paper, but Byron?
Yeah, it's a great topic. So part of my role is to live in tension with the reality of artificial intelligence, sort of being embedded in the products and the services that we offer, either through vended solutions or through your co-developments or through your internal developments. 84% of what we have deployed is considered internally developed or co-developed. Strategy behind that is to preserve optionality. And that's because many of the solutions that we see today are of a temporal, in a temporary state. Many of them won't survive. And so you want to preserve your optionality so that you can switch out as almost like a replaceable part. That is one way when things become constrained that you can pivot. But to a certain degree, everything is going to become, because we're not paying for all those electrons that are moving in the data centers right now. And be reminded, essentially, a lot of this is elegant math, right? And it's used in many ways so that we can understand and discern it a little bit more. But that's what it is. It's electrons moving a bunch of zeros and ones in an elegant coordination, and doing that and creating services with it. Role is to ensure that we can adopt the technologies responsibly, that we can follow the norms that are being here, embed that in the products and services to help everyone hopefully sleep well at night and flourish. But then also to improve and preserve our optionality so that we're not stuck.
Well, we're going to have to call it there. I'm going to remind you at the bottom of the screen here, you'll see that additional comments can be submitted to me. If we crowdsource this, if you send me your comments and insights, I'm sure it'd be incredibly rich and very helpful to us. So please don't hesitate to do that. But I want to thank the AI Working Group for their incredible work, and excited to see us bring it across the finish line. Thank you.